everyone, I'm here again. My name is Dr. Priti Anand and I'll be covering the RRR YouTube series of MRCOG Part 2, the Urogynaecology module. So I'll be taking some questions in a stepwise format of the management, so that will help you in understanding and the concept. One thing which everybody should know is any patient of urogynec who comes to a urogynecological clinic or a general gynec clinic, it is very important if they have urinary symptoms, urine dipstick should be done. Okay, whether they don't have burning and dysuria, still they have frequency urgency, you should always check the urine dipstick in that case. Now, the first case is a 45-year-old woman, 4 children with the urogynecological clinic, urgency, urgent continence. There is no significant past medical history. Not taking any medications, her BMI is 35 on the higher side, drinks 3 cups of tea every day, and urine analysis is normal. So what will be the next step in her management? Okay, we can see the lead statement here, most appropriate next step in the management. So definitely you will give her some advice to lose weight and drink less coffee, but it is very important in this case to have a bladder diary done. Okay, the next step for this patient is to have a bladder diary. Okay, because her dipstick is negative. Second patient with the same symptoms, urine dipstick negative. You have made a diagnosis of urge urinary incontinence with respect to her history taking and reviewing the bladder diary. Now, what will be the most appropriate next step? To give her a bladder training. Okay, so first thing is a bladder diary, urine dipstick, bladder diary, and bladder training needs to be done. Same patient is taken with the complaints of urgency, frequency, nocturia. She feels she empties the bladder completely, but there is a frequency and urgency increasing. Not completely relieved by bladder training, which you have given her, and modulating fluid intake. Now, what is the next step for her? Because now with the conservative management, nothing is helping her. The best step is to give her a medical management with the first line drugs which are given for the OAB is the anticholinergic. So oral oxybutynin is a drug of choice first to be given. 55-year-old lady, same condition, has been given the oral oxybutynin, but she suffers a lot of side effects from the oral oxybutynin. So what is your next step? Do you stop it? No, you convert because she was responding, but the problem is the side effects. So what you can do, you can convert oral oxybutynin to transdermal oxybutynin. Same patient is there, but despite of transdermal oxybutynin, she has a side effect. Or in case they give you in the question that anticholinergics were given to her, but they were not affecting her. Or the patient has a contraindications, certain medical conditions where you can't give anticholinergics. So in these patients, for the medical management after the conservative management has failed, is the Mirabegron. Okay, so these are the 3 conditions where Mirabegron is given. Oral oxybutynin or oral anticholinergics are always the first choice. If the patient is responding to oral therapy, but she has side effect, convert oral to transdermal. If the patient has side effects from oxybutynin, even oral and transdermal, contraindications for anticholinergic, or they are not effective at all, oral, transdermal, nothing is effective. Then you shift the patient from anticholinergics to the Mirabegron. Same patient is there who has been taking the oral preparations. Conservative management is, no, now the patient has changed. Sorry, it was the previous question. 82 years old lady with the frequency and urgency, OAB, started with the medical management and conservative management, started with the conservative management, which has not helped her. Now she's yet to start the medical management for OAB. Now, important here is to consider the age. Here, the age was 55 in the previous questions, right? You gave oxybutynin, but for the lady who is 82 years old, you can't give oxybutynin. Okay, they have cognitive problems that will happen. So these patients, the best treatment for choice is oral tolterodine. Okay, oxybutynin is not given in this age group. So usually, roughly, if I say, I have no specific guideline, RCOG guideline, which gives the cutoff for the age, but 75 and above, they don't give oxybutynin. Okay. Then patient with urgency, incontinence, detrusor overactivity, which is diagnosed on urodynamic study, conservative and medical management has failed. Now, what is the next step? Because it is a urodynamic proof, so botulinum toxin can be given. Remember, if medical management fails, first step is an MDT review for urodynamic study. If that is showing that it is an OAB, you ask the patient, do you agree for the intermittent self-catheterization if required? She says yes, then botulinum toxin intravesical is the best treatment next. Same patient is there as question number 8, but here the patient refuses that if the intermittent self-catheterization is required, I'll not do that. Okay, so botulinum toxin is not a good choice for her. So because medical management is failed, botulinum toxin you can't give. The surgical management, that is percutaneous sacral nerve stimulation, is something which is required for this patient. Okay, the next step in management. So OAB treatment is always OTD in this format, oxybutynin, tolterodine, derifenacin. I have told you there are certain contraindications for anticholinergics like glaucoma, angina, and pregnancy. Okay, otherwise dry eyes, dry mouth are the certain commonly seen side effects from these drugs. There was one more important question that there is a 61-year-old lady who is having a bladder training for incontinence for 12 months, but it's not helping her. Most appropriate next step. Now, in this patient, the next step will be oral oxybutynin. Okay, but unfortunately, that is not an option. So, do we go for the oral transdermal oxybutynin? No. The oral therapies are preferred over the transdermal preparation. So, if the oral oxybutynin is not there, we'll go for the next choice, that is T. Oral T, that is oral tolterodine will be the next choice. These are the options for a set of questions which I have just prepared. I'll just take you through that. So there's a patient who has a frequency, urgency, urge incontinence, SUI symptoms, no other medical comorbidities, bladder diary shows she drinks 4 liters of water in a day, very high, 10 times she avoids 2 times at night. Mild asymptomatic rectocele is there. She has going through pelvic floor muscle training, refuses any surgery for SUI, and what 4 liters of fluid, anybody can have frequency, urgency, and SUI. So the first step, if you see in the late statement, most appropriate management for this patient is to tell her, please reduce your fluid intake. Okay, so the fluid intake, if she'll reduce, definitely that will be helping her. Second patient is a stress urinary incontinence, does not wish any invasive intervention as she has to take care of her husband who is very sick. She has completed 3 months of pelvic floor muscle training, which is not helping her. Now, what is the next step in management? So we all know the stress urinary incontinence, PFMT is the first choice. If that is not helping, we take the patient to the surgical options. She can't undergo surgery because of her condition in the family. So what to do next? Duloxetine even is a never second choice drug for SUI. Second line treatment, it is even not a second line treatment. This patient requires something effective, not surgical, major surgical like colpo suspension, but at least something which can help her, which is effective. Okay, duloxetine, as I said, has a lot of side effects. It's never a second line management. So this patient is a candidate for the intraurethral bulking. She completely, okay. Deepti, just a moment, dear. Just a moment. So I have another set of questions for these options. Now, if you see the lead statement, it says that what is the most appropriate management option? Okay. So the first question says patients has frequency, urgency, stress urinary incontinence, no medical comorbidities. She takes 4 liters of water in a day, urinates 10 times in a day, 2 times at night. Mild rectocele is there. She has PFMT done. She refuses any surgery for SUI. And the lead statement said what is the most appropriate management option. Any patient who is drinking 4 to 5 liters of water in a day will have frequency, urgency, and SUI. Okay. So first thing, most appropriate for this patient, even if you give her bladder training or anything else, will not help her unless she reduces her fluid intake. Okay. So the next most appropriate next step in her management is to reduce the fluid intake. Stress urinary incontinence patient does not wish any invasive intervention because husband is sick. 3 months trial of supervised pelvic floor muscle training with no improvement. So these patients who have PFMT tried do not want to undergo the major surgery. Drug like duloxetine can be one of the choices for them. Okay. So most appropriate because she does not want any major surgery because SUI treatment is PFMT fails, go for surgery. Okay. So because she does not want any surgical method, so duloxetine is a drug of choice. Third patient is following surgery. She develops SUI. She wants more children in future and religiously following PFMT, but is not helping her. Now, in these patients, even if you do corpus suspension, in future when she'll deliver, that will fail. So she is not a candidate for corpus suspension. And look at the question, she's not refusing for anything. Okay. So if she wants, she understands the risk, it's okay. But corpus suspension, she's not a candidate for that. Again, duloxetine is never a second line management. It is only a line of management where patient completely refuses any surgical intervention. But in this case, better is to give her intraurethral bulking agents than to take her for the duloxetine. Okay, duloxetine, as I said, it's not even a second line management. Corpus suspension, if you do, it will fail after her next childbirth. So intraurethral bulking agents is a best option for this lady. Patient with SUI, stress urinary incontinence, tried pelvic floor muscle blending, no benefit. What to do? Definitely first corpus suspension, which is a management option. Now, if the patient purely has SUI, you do not even require to do a urodynamic study. Okay, you can directly take the patient for corpus suspension even without a urodynamic. But if she has a prolapse, then definitely you'll do a urodynamic and then only you will go for the SUI surgery. If the patient with multiple sclerosis has retention of urine, what do we advise them? Self-catheterization. Undergoing mid-urethral sling procedure for SUI 10 years ago, she has already undergone a surgery. Again, she presents with SUI, but she has a good pelvic floor muscle tone. That means even if you give her PFMT, it is not going to help her. SUI plain can go for surgery without any urodynamic study. SUI with prolapse after surgery, before surgery requires a urodynamic study. And SUI who has been previously treated in the past and has a recurrent of SUI, then before doing any surgery, you have to do a urodynamic. So most appropriate next step in this patient will be to do a urodynamic, and then you can plan whatever is required. Okay, so these are some slides which can help you. Okay. So again, the lead statement in says single most likely diagnosis or cause of urinary symptoms from the list of options in this case, in these cases. So you can see that the list of options gives us various type of diagnostic, what type of diagnosis you make from the presentation over here. So there is a 35-year-old para 4. She has complaints of urgency, frequency, and incontinence. She's a teacher, describes an almost constant sensation of needing to pass urine. Impossible to wait for the break in between the classes. The episodes of incontinence are associated with increasing urgency, but they are rare. Gynecological examination is normal. Bladder diary shows she voids 12 times in a day. So 4 to 8 is usually normal. Functional bladder capacity is 300, which is 4 to 600 is usually normal. Average voided volume is 150, approximately good amount. Cystometry, that is a urodynamic study, shows no incontinence. First desire, it has 100 ml. So 150 to 200 usually as a first desire. Strong desire at 300 and no observed increase in the bladder pressure during filling. So you can see a urodynamic study, P vesicle is increasing with pre-abdomen. That is, whenever you are asking the patient to cough or sneeze, increase the intra-abdominal pressure, it is very likely the abdominal pressure and vesical pressure will increase. In the normal study also, it will increase. No leak with that, that means there is no SUI. No changes in the detrusor pressure is there, that means it is not OAP. But EMG shows that the bladder muscles contracts, relax during the course of the study. That means this patient is suffering from sensory urgency. Okay. So it is increased bladder sensations during filling, which makes desire to void again and again. Low bladder capacity is noted. So this patient has sensory urgency. There is definitely PDT is not increased. So there is no AAB component over here. 59-year-old para 2, urine leakage on coughing, sneezing, lifting, bending. BMI 30, she has to wear the incontinence pad. BMI 30, evidence of low genital atrophy is there. 59 years, we can expect that. Stress incontinence, there is no demonstrable stress incontinence. That is on examination, they are not able to see it. Filling bladder cystometry shows that first desire of void is very early, urgency is very early, associated with a high detrusor contraction, which is also very high and resulted in the completed bladder emptying. So when you see it at the urodynamic graph, you can see that with abdominal pressure, there is increase in the vesical pressure, but there is no leak seen. Okay. This leak is when she starts voiding. Okay. Leak before you are voiding is a urge incontinence, basically a type of incontinence. But PDT is increased. PDT is increasing with P vesicle. So if PDT is increasing urodynamic graph, it is always a case of OAB. And because this is a leak before she starts passing urine, so it is a kind of wet OAB. Okay. So the urodynamic diagnosis of this patient is detrusor overactivity, not overactive bladder. It is detrusor overactivity. So choose your option wisely. It is detrusor overactivity answer, not overactive bladder. Okay. Because it is a urodynamic diagnosis which you need to give here because they have given a urodynamic graph over here. Okay. So the urodynamic diagnosis is detrusor overactivity. Okay, so the patient is 82 years old. Prolapse symptoms are there. Hysterectomy done 40 years ago. She's not sexually active, does not wish to have surgery. POPQ stage is there. So you can understand from this POPQ stage, everything is out. Everything is in a plus. So everything is out. D is absent. That means it is a vault prolapse. So it is a total vaginal vault prolapse. In this patient, surgery basically might be the good option, but she does not want surgery. So the first option, conservative, pelvic floor muscle training and pessaries can be given. She is not sexually active, so you can use either ring or Gellhorn. Both are effective. Gellhorn pessaries are usually not recommended in the patients who are sexually active. Okay. If you give also, then you have to remove the pessary before the sexual act. So in this patient, ring and Gellhorn pessaries are both effective because she does not want surgery, and pessary can be one of the helpful option. And because she is not sexually active, so both are equally effective for her. Okay, and it is a total vaginal wall prolapse. So these are the various type of pessaries which come. So you can understand that Gellhorn pessaries are something which totally block the vagina and are required to be removed when the sexual act happens. 77-year-old woman is referred to gynecological clinic because of prolapse symptoms. She had a hysterectomy done 20 years ago, suffers from occasional constipation, no urinary or bowel symptoms, no urinary leakage on straining. Following counseling, she agrees to undergo the wall prolapse surgery. Okay. Now, if you see in this case, the upper compartment is in its place. -3 means the original place it is. Whereas the lower, the posterior compartment has coming out. So basically, she has a posterior vaginal wall prolapse. Okay. So she requires a repair of posterior vaginal wall defect, but without MASH. Okay. Remember, as far as possible, NICE guideline completely says that you do not use MASHes as far as possible in any type of prolapse surgery. 76 years old lady who has the prolapse symptoms, hysterectomy done 30 years ago, no other symptoms, bowel or bladder. Clinical examination confirms the vaginal wall prolapse. With respect to the choice of operative procedure, what will be the best choice for her? Now, because it is a total vaginal wall prolapse, the best choice for this patient is a sacrocolpopexy. Okay, so usually these patients, sacrocolpopexy is a good success rate over sacrospinous ligament fixation. So sacrocolpopexy is always better option, and because she is sexually active, so sacrospinous ligament fixation is not a good option. SSF is not a good option for her. So sacrocolpopexy open is associated with lower reoccurrence rate as compared to sacrospinous ligament fixation. And in sexually active, we do not do SSF. One more reason. So this patient will be treated with the sacrocolpopexy. 60 years old yoga trainer, sexually active, referred by GP to gynecological clinic because of sensation of bulge. Vaginal hysterectomy was done 10 years ago. She does not have any problems with respect to bladder and bowel. On examination, there is a stage 3 wall prolapse. She wishes to get back to her job as early as possible. What is the most appropriate treatment option? Okay. They have mentioned that she is sexually active. Again, no. Deepti, just a moment. Can I stop once? So next case is the most appropriate treatment option. So Mrs. Oshutio, 86 years old, underwent hysterectomy 30 years back, now have vaginal wall prolapse, hypertensive, diabetic, coronary artery disease, pulmonary hypertension. On examination, she has a wall prolapse of stage 3. Appropriate surgical method for her. Okay, these patients can be treated with the pessaries. Okay, PFMT can be given, pessaries can be given, but stage 3 prolapse, pessary will really be difficult to hold. Okay, and because in the question they have asked the surgical management of choice for this patient, extremely friable and frail patient with so many medical conditions, the best, not sexually active, is to do a corpoclasis. Okay, so this patient is the best candidate for corpoclasis, which is safe, effective in patients who are frail and do not wish to retain the sexual function. Other alternative can be passive, but since they have asked about the surgical management, as I just told you, corpoclasis can be the best option for. Okay, but as far as possible, these patients are treated with the conservative management of pessaries. Not helping, then corpoclasis can be done. Okay, rest it is up to the question which they have mentioned. So according to that, the corpoclasis is the correct answer. Okay. So I think I've shared a lot of questions related to urogynec module in a format that you will understand the concept about the each OAB and the stress urinary incontinence, and it will help you in your exams. So all the best from my side. Thank you so much for watching, and God bless you all. Thank you so much.